Likewise, pulmonary eosinophilia. So there are some eosinophilic diseases of lung. Like we discussed, IG is the pathology involved in bronchial asthma. Of course, eosinophilia is also a part. There are some other diseases causing pulmonary eosinophilia. So low-flow syndrome. What is low-flow syndrome is red ascariasis, hookworms, schistosomiasis. A part of the life cycle of these worms, these are roundworms, usually involves the lung also. So the worms travel through the lung. When these worms travel through the lung, it induces eosinophilia. So strongyloidosis, these drugs, Paragonimus westermani, which is called as the lung fluke. Even filariasis. So all these worms or parasites cause an eosinophilic reaction in the lung. There are many other causes of pulmonary eosinophilia. So what we are discussing here is the tropical pulmonary eosinophilia or low-flow syndrome. Okay. So while discussing bronchial asthma itself, we are discussing the associated things. So we discussed occupational exposure to few dust. For example, bicynosis, where the cotton dust, when it is exposed, it leads to a syndrome like bronchial asthma. But there are conditions where, apart from bronchial asthma, the lung parenchyma or the lung pleura may be involved in few other occupational lung diseases. So we will discuss the classical ones. Asbestos. So asbestos is produced in construction, shipper industries, mining and processing. So asbestosis is very well known for its fibrosis. It causes pleural plaques. Pleural fibrosis, pleural plaques. So an advanced form of pleural disease is pleural mesothelioma, which is a cancer arising from the spindle cells of the pleura. So it can start from just a pleural fibrosis to pleural disease. I'll show you the images. Then we have silica. So silica is produced from mining, quarrying, stone industries. So what does silicosis do to the lung? So it causes fibrosis. Okay, asbestosis also causes fibrosis, but it is pleural fibrosis. Silica causes lung fibrosis. When fibrosis is more, it is called as PMF, progressive massive fibrosis. And never forget tuberculosis, because silicosis is usually associated with tuberculosis. It is said that the silica particles interfere with the macrophage invasion of the tubercle bacilli, so tuberculosis can grow. So that silicosis plus tuberculosis, we call it as silicotuberculosis. This association is very important. It can lead to COPD. Now what about coal dust? It is called as coal workers pneumoconiosis, CWP. That is also fibrosis. And in advanced stage, we call it as progressive massive fibrosis. Beryllium can be involved, berylliosis. Okay, beryllium causes pneumonitis. So based on the type of occupation, based on the type of presentation, we can discuss. See, cotton dust also we discussed. It causes asthma-like syndrome, bicynosis, which we just now discussed. Of course, many other toxic gases and things can cause hypersensitivity pneumonitis or bronchial asthma, or it can cause fibrosis or massive, progressive massive fibrosis. We'll discuss some pictures. See, this opacity is like a leaf, right? So this is a pleural plaque of asbestosis. It is not a lung opacity, it's a pleural based opacity. This is also another image showing a pleural plaque. See here, some opacity is outside, and this pleural plaque in late stage, this will become mesothelioma. If you see this disease, again the clue I am giving here is patient is a mining worker. So definitely some occupational lung disease only we are discussing. What presentation is here? The lung fibrosis, lung parenchyma is involved. There is extensive fibrotic lesions. See, how will you say it is fibrosis? There is honeycombing, okay, like interstitial opacity. So this is progressive massive fibrosis. Can occur in coal workers pneumoconiosis or silicosis. Since I told he is a construction worker, this is silicosis. This is another image of silicosis. You can see there is fibrosis, probably some cavitation involving the upper lobe predominant. So if you trace the rib, is the second rib, right? Above the upper rib is called as above the second rib is called as upper zone. So silicosis will be usually upper and mid zone predominant. So this is also another image. So this is about the occupational lung disease. So why we came to all these diseases is they are closely related to bronchial asthma, right? Bronchial asthma, hypersensitivity pneumonitis, occupational lung disease, they carry the same pathology, exposure to allergens. Now we will discuss about COPD. So COPD has three pathological processes. One is chronic bronchitis, second is emphysema, third is small airway disease. For everything there is a clear definition. Chronic bronchitis is defined as cough with sputum production or cough with expectoration. For 3 months in a year, for 2 consecutive years. This is the correct definition of chronic bronchitis. Emphysema is permanent destruction of alveoli. That's the simplest definition because there is another term called as bronchiectasis. Bronchi means bronchi, ectasis is dilatation. So this bronchiectasis means permanent destruction and dilatation of bronchi. So bronchiectasis is another airway disease. So COPD we are discussing under the heading of airway disease, but I am telling you emphysema is a permanent destruction of the alveoli. Because COPD is not only an airway disease, it's actually a complete lung disease. That's why the term chronic obstructive pulmonary disease. It's not only an airway disease, it's a pulmonary disease. Also we have a variant called small airway disease. So chronic bronchitis involves the larger airways, small airway disease involves the smaller airways, emphysema involves the alveoli. That is why while discussing about pulmonary function test, there won't be irreversibility. There will be FEV1 by FEC reduction because of airway involvement, but also there will be hypoxia and some other changes because of emphysema, right? So this is how the GOLD classifies. GOLD is an international organization which gives criteria and definitions on COPD. So I told you FEV1 by FEC less than 70% is only COPD. Its severity is classified. So whether it is mild, moderate, severe or very severe, FEV1 by FEC is less than 0.7. But what criteria? They say the severity is by seeing FEV1. If FEV1 is more than 80%, it is mild. FEV1 50 to 80% is moderate. 30 to 50% is severe, and less than 30% is very severe. This is how they classify COPD. So what are the symptoms now? Airway is involved, so there can be wheeze. Emphysema, parenchyma is involved, so there is cough, expectoration. Of course, in chronic bronchitis also there is cough and expectoration, that is the definition. And there is hypoxia. There is exertional breathing difficulty. Okay, and we know the spirometry. FEV1 by FEC less than 70%, and we have to see the FEV1 till the grade, and there is no bronchodilator reversibility. By far the most common cause of COPD is smoking. If you have to tell one reason for COPD, it is smoking. But still there are some congenital causes also. For example, a disease called alpha-1 antitrypsin deficiency. It is an enzyme which breaks down some enzymes of the neutrophils. When alpha-1 antitrypsin is deficient, the neutrophils will be activated more and they destroy the lung. So how to classify whether emphysema is due to smoking or is it due to congenital cause? For that, we should know the pattern. See, emphysema is destruction and dilatation of the distal airway. So you can see the dilatation and distension here, right? In this place you can see it here. Nearly everywhere, in many places unrelated you can. And in this case you are seeing only very close to the bronchus. So these are the three different patterns of emphysema. So if this image is shown, this is centrilobular, that is close to the bronchus, right? Centrilobular emphysema means it is smoking. This is panlobular emphysema, like every part of the lung, panlobular emphysema. Every part of the lung has emphysematous chambers. This is typical of alpha-1 antitrypsin deficiency. Okay, this is another variant called as paraseptal emphysema. This is also seen in smoking. So centrilobular and paraseptal emphysema is mostly smoking. So that is localized emphysema means it is smoking, whereas generalized emphysema it is alpha-1 antitrypsin deficiency. So try to remember this if you can, or I'll make it a little bit simpler. How do you tell the severity of COPD? We have to tell about two criteria, whether they are symptomatically mild or moderate or severe. So one is the symptomatic criteria, next is the exacerbation criteria. Because less symptomatic, less exacerbation is treated differently. Very symptomatic, frequent exacerbation is treated differently. That is what this one. So we have four, right? So how will you classify COPD severity? By the MMRC score. So we know the MMRC score. MMRC 0, there is no breathlessness except during strenuous exercise. MMRC 1 is breathing difficulty while hurrying on level ground or walking up a hill. MMRC 2 is walk slower than people of the same age group, or on level ground they have to stop. MMRC 3 is they become breathless and walking just 100 meters. 4 is too breathless to leave the house. So this MMRC 0 or 1 is mild symptomatic. MMRC more than 2 is severe symptomatic. There's another scoring called as CAT. To avoid confusion, let us skip that. The other way is by the exacerbations. In 1 year, if there is 0 or 1 hospital admission, it is less frequent. 2 or more means more frequent. So by the severity and exacerbation only it is treated. This is the simplest 2026 gold treatment policy. Right? So I told you two things: severity and exacerbation. Right? Severity and exacerbation. So here severity is given here. MMRC is low or MMRC is high, and based on the exacerbations. Take the simplest one. They are less symptomatic, there is no exacerbation, only a bronchodilator is enough. That means only one bronchodilator is enough. Suppose the disease is severe, or suppose there are more exacerbations. So the maximum category, whether the exacerbation is more than 2 per year, or if the severity is more, then you have to give combination of LABA and LAMA. You can very well see in bronchial asthma, I told the controller therapy, that is inhaled corticosteroid, is the most important treatment. It is the pathology changing drug. Whereas in COPD, ICS is not given. Right? What they are given is LABA plus LAMA. It's a 2 bronchodilators. So we had discussed, since small airway disease is one variant, this LABA acts on larger airways. LAMA acts on smaller airways. So both the airways get dilated when we give LABA plus LAMA combination. Since the pathology is not related with any inflammation, I mean, it's not related with interleukin 4 or steroid responsiveness. Inhaled corticosteroids do not have a role. They may be used in situations where eosinophilia is present. We had a short discussion on pulmonary eosinophilia, like tropical pulmonary eosinophilia, Loeffler syndrome, and diseases like that. If eosinophilia is there in COPD, it can be given. And steroids can be given if asthma COPD overlap. There is an entity called asthma COPD overlap. In this condition, it can be given. Or there are frequent exacerbations. Very frequent exacerbations. Apart from this, there is no role. So the latest treatment says this one, only LABA and LAMA is given. In advanced cases, again we can give oral bronchodilators. The best therapy ever is stop smoking. And patients may need long-term O2 therapy. It's called as LTOT, long-term oxygen therapy. In severe emphysema, they may need long-term oxygen therapy. Because what happens if you don't give oxygen therapy? In COPD patients, there will be chronic hypoxia. We know very well that hypoxia anywhere in the body causes vasodilatation, except in the pulmonary circulation where it causes pulmonary vasoconstriction. This pulmonary vasoconstriction leads to pulmonary hypertension. So there are 5 types of pulmonary hypertension. This type of hypertension comes under group 3. So I'll tell you what is that. It is group 3 pulmonary hypertension. Long-term pulmonary hypertension leads to right-sided heart failure. That is called carpulmonale. So only few lung diseases cause carpulmonale. Right? Any chronic lung disease like COPD, interstitial lung disease, bronchiectasis, obstructive sleep apnea, chronic chest wall diseases. So most of these things can cause carpulmonale. That is why if you give oxygen therapy, it prevents all these things. So stopping smoking, long-term oxygen therapy, LABA plus LAMA combination, steroids SOS, this is the oral treatment. At this juncture, we will discuss about types of respiratory failure. There are 4 types of respiratory failure, type 1, 2, 3, 4. We will discuss only 1 and 2, the most important types. Type 1 is also called as hypoxic respiratory failure. Type 2 is called as hypercapnic respiratory failure. Type 1 respiratory failure is also called as an exchange problem. This one is a ventilation problem. We had discussed earlier, major part of the airway, the function is only ventilation, that is taking in oxygen and leaving out carbon dioxide. Whereas the problem with the respiratory membrane, that is the part of the alveolar endothelium, the interstitium, and part of the capillary, the function is gas exchange. So if there is a problem with gas exchange, for example, you can think of the diseases like ILD, pneumonia, etc. The respiratory membrane is damaged, so there will be hypoxia alone, right? What happens to CO2? Carbon dioxide will not be affected even if the respiratory membrane is damaged, because carbon dioxide is a drug which has a high diffusion coefficient. It's a physiological fact. Carbon dioxide has a high diffusion coefficient. So even if when the respiratory membrane is damaged, CO2 can enter from the blood to the airway, alveoli, and it can get exhaled out. So when the respiratory membrane is damaged, oxygen will be the main problem. So how will you treat this? By giving oxygen. On the contrary, when you think of a ventilatory problem, for example, there is COPD, there is obstructive sleep apnea, there is a neuromuscular junction disorder causing a problem, there will be problem with the muscle itself. There will be problem with the ventilation itself. So O2 is not taken in, so that will lead to hypoxia. and carbon dioxide is not exhaled out. So carbon dioxide will increase in blood, that will lead to hypercapnia. Okay, so hypoxia will occur and hypercapnia will occur. Here, be cautious on using O2. So don't write oxygen as the treatment despite being hypoxia, because this hypoxia stimulates the respiratory center in the brain. Hypercapnia also stimulates the respiratory center in the brain. But which is the strongest stimulus is hypoxia. So we'll erase off this one. So it is the hypoxia which stimulates the respiratory center in type 2 respiratory failure. So this leads to increased respiratory rate and increased efforts on breathing. What if you correct the hypoxia? I already told you, in COPD or airway diseases, there is on giving oxygen, their oxygen will improve rapidly, unlike shunt mechanism or unlike ventilation perfusion mismatch. So when you give even smaller amounts of oxygen, O2 will be normalized. When O2 gets normalized, the hypoxia will get corrected. Without hypoxia, there is no stimulation of the respiratory center. So their tachypnea efforts will get reduced. So CO2 will keep on accumulating, because only when respiratory rate increases, CO2 can get washed out. So if you correct the hypoxia and COPD or type 2 respiratory failure, CO2 will increase much and it will lead to carbon dioxide narcosis. So here our efforts must be to not only to correct the oxygen. So it is enough if you keep the SpO2 target between 88 to 92%. You need not normalize the saturation in type 2 respiratory failure. All you have to do is you have to increase ventilation. How can you do that? Non-invasive ventilation. Either the continuous positive airway pressure or bi-level positive airway pressure mode in the ventilator. That's why the term ventilator. Ventilator helps with ventilatory respiratory failure. Of course, it can also be used in type 1 respiratory failure provided O2 fails. Only when O2 fails, you keep non-invasive ventilation. If you need to intubate the patient, you can go for intubation and ventilation, invasive ventilation. But O2 is not the treatment of choice for type 2 respiratory failure, it is ventilation. Right? So we discussed respiratory failure along with this because COPD is a very important ventilatory disease. Now we will continue with the other ventilatory airway disease, which is bronchiectasis. So we discussed bronchiectasis is a destruction, permanent destruction of the bronchi. Bronchi can be proximal bronchi, middle bronchi, or the distal bronchi. Based on that, there are so many classifications: proximal bronchiectasis, distal bronchiectasis, etc. So one type of classification is focal bronchiectasis. For example, only one place there is bronchiectasis, always think of a mass which is occluding or a foreign body which is aspirated. Right? Now diffuse bronchiectasis. Diffuse bronchiectasis definitely will invite more questions. It could be due to infection. It could be due to immunodeficiency. Why immunodeficiency? There is a vicious cycle in bronchiectasis. Assume that there is an infection. When infection is there, there will be inflammation, local destruction of the airway. Destruction of the airway invites more stasis of secretions, leads to more infection. So it continues on. That's why in immunodeficiency, infection will be there. It forms a vicious cycle. So infection, immune. So what are the syndromes which can cause bronchiectasis? Cystic fibrosis is a very important syndrome which we will discuss now. There is something called Cartagena syndrome. Right. There are so many other syndromes. Why Cartagena syndrome? Cartagena syndrome is a problem with the motility. The ciliary dysmotility will be there. So when cilia is dysmotile, they cannot function well as innate immunity. We know very well, one of the brush border of the epithelial cells or the respiratory epithelium is a form of the innate barrier, innate immune system. So when the cilia becomes immotile, they cannot push out the pathogens out. So that's why cartaginous syndrome, etc. cause problem. Aspiration is also a DD for bronchiectasis. We have other syndromes, yellow nail syndrome, etc. We'll discuss cystic fibrosis here. So image wise, there are very many types. Tubular bronchiectasis, cylindrical bronchiectasis, varicose bronchiectasis. Different type of bronchiectasis will produce different finding. For example, there's something called signet ring, occurs in cylindrical bronchiectasis. We have grape-like clusters. See, many of the findings are given here. Bronchiectasis is nothing but dilatation of bronchi. Here you can clearly see bronchus is dilated, right? Air-filled cavity is bronchus, it is dilated. Normally you should not visualize bronchi here. When it comes in clusters, we tell it as grape bunch of grapes appearance. When it comes like this, see, this looks like a ring, right? Signet ring. This is the signet ring appearance. Sometimes when linear thing comes, it is called as tram tracking appearance. See, this is tram track. So this image gives many features of this one. Tram tracking, bunch of grapes appearance, and signet ring appearance. So coming to cystic fibrosis. Cystic fibrosis is one cause of bronchiectasis. Its pathogenesis is very simple. There are chloride channels in the respiratory epithelial membrane. There are chloride channels in the sweat glands. So there is a mutation called as delta F508. F is phenylalanine. Delta is deletion. So when the phenylalanine of 508 gene position is deleted, what happens is a particular protein called as CFTR protein is not produced. CFTR is cystic fibrosis transmembrane receptor protein. It is normally a protein which is present in the ciliary epithelium. Its function is a chloride channel. So either it pushes the chloride out or takes the chloride in to maintain secretion. So CFTR is nothing but a chloride channel. When this delta 508 is deleted, what happens? CFTR is not produced. So what happens to the chloride transport? Chloride transport becomes abnormal. So in some tissues, chloride will not be taken in from the cells. In some tissues, chloride will not be secreted out. But whatever happens, what you have to remember is respiratory secretions or most secretions become dry. That is why when respiratory secretions become dry, it becomes a source of infection. Infection leads to stasis. Stasis leads to further infection. So they say there are 6 classes of mutations. So the commonest mutation is class 1. It is deletion of phenylalanine, leads to absence of synthesis. That is the first step. That is, the protein itself is not synthesized. Of course, there are other mutations, like there are minor mutations. There may be problems in the protein synthesis. There may be problems with the binding. There may be problems with the expression. Right? Class 3 is about problem with hydrolysis. Class 4 is it is expressed in the cell, but there is defective conductance. So at least remember class 1 is the most common variant. So this is what happens. See, this is an example where the salivary gland, submucosal salivary gland, normally it should secrete chloride. But when this is problematic, so this should normally secrete chloride. When this CFTR gene is not there, chloride will not be secreted, so secretions will be thick. In sweat glands, what happens is chloride is not taken in, right? Or in other words, sweat has more chloride in cystic fibrosis. This point is very important because it leads to a very important clinical finding, the salty baby syndrome. Usually mothers complain that the baby is salty. Okay, when the mother kisses the baby, she recognizes that the baby is salty. So this is one finding. So in sweat glands, chloride is secreted, so baby will be salty. But in most of the other places, like in pancreas or in respiratory epithelium, secretions become thick. So that leads to bronchiectasis. So not much of treatment is available because the treatment of bronchiectasis itself is secretions are there. So we have to immunize against infection. Usually pneumococcal vaccine, pneumococcal conjugate vaccine, and we give influenza vaccine. This is commonly given. Next, chest physio to prevent secretions from accumulating. And whenever there is infection, we have to give antibiotics. This is how bronchiectasis is treated. Mainly chest physio and postural drainage is the mainstay. So which infection is very common? We have Pseudomonas infection and Burkholderia cepacia. These infections are common in bronchiectasis. So how will you screen for cystic bronchiectasis, cystic fibrosis? One, again, sweat chloride levels. The cutoff here is 60. So when sweat chloride is more than 60, it is definitely cystic fibrosis. When it is less than 30, it's definitely not cystic fibrosis. 30 to 60 is intermediate, where we can do genetic testing to find out delta F508. How will you treat? We have CFTR reactivators. Like linaclotide. And we have a drug called as lubiprostone. They increase the chloride channel secretion. Apart from this, much therapy is not available. Okay. So this finishes bronchiectasis. So we have discussed bronchial asthma, we have discussed COPD, we have discussed bronchiectasis. So the three most important airway diseases. We will discuss obstructive sleep apnea sometime later. Now what about interstitial lung disease? Interstitial lung disease is actually a group of diseases. It's not a single disease. We finished airway. So interstitial lung diseases are a group of diseases where the interstitium of the lung is affected. Okay. So we already discussed how does it manifest. It presents only with dry cough. But also remember, interstitium is one part of the respiratory membrane, right? We know that the alveolar epithelium, the interstitium and capillary endothelium, these three form mainly part of the respiratory membrane. So in ILD, respiratory membrane is affected, so it leads to hypoxic respiratory failure or type 1 respiratory failure. And chronic type 1 respiratory failure can lead to pulmonary hypertension, which can lead to carpulmonale. That is why this disease is most dangerous. Unless you give supplemental oxygen, long-term oxygen therapy, ILD is very dangerous. So, what are the causes of ILD? There are many different types of ILD. At least remember two important diseases. One is IPF. IPF is idiopathic pulmonary fibrosis. As the name suggests, it is idiopathic. That is, it occurs without any reason. The other ones are usually associated with some systemic diseases. So how will you proceed with IPF? First, you should have a suspicion that there is a dry cough. You get a clinical finding in ILD which is called as Velcro crackles. That is fine basal end-expiratory crackles in the lungs are called as Velcro crackles. This is the clinical examination finding. Apart from that, we do a routine thing, pulmonary function test. What does the pulmonary function test reveal in ILD? It is a restrictive lung disease. It is intrinsic restrictive lung disease. So what are the findings here? FeV1 by FVC will be normal. DLCO will be reduced. And what happens to the total lung capacity? It is reduced. Residual volume is also reduced. So symptoms, breathing difficulty, cough. Examination findings we discussed. So why does it occur? Genetic findings. Some are exposed to smoke, but it's not usually smoking related. The most important thing apart from the pulmonary function test, what we have is HRCT and histopathology. In histopathology, we call the typical pattern as UIP, universal interstitial pattern, but this is not usually done, but most of the thing we can diagnose it only by HRCT. So what are the findings? So we usually here have a usual interstitial pneumonia pattern. Remember these terms: reticular changes, honeycombing, traction bronchiectasis. These are the findings which are seen. Non-specific interstitial pneumonia, this occurs secondary to some diseases. Okay, this occurs secondary to some diseases like rheumatoid arthritis or SLE, some systemic autoimmune diseases. Here clubbing is less common. In IPF, clubbing is there. Clubbing is one of the lung diseases. ILD is one of the lung diseases where clubbing is there. Which type of ILD? It is IPF. Which are the other diseases which cause clubbing? Lung abscess, empyema. Okay. So clubbing is less common in NSIP. I told the diseases which are common. See the HRCT findings here. In IPF, it is usually honeycombing, traction bronchiectasis. Here it will be ground glassing opacity, reticular pattern. Honeycombing is rare. Okay, honeycombing is a finding of IPF. And we have the histopathology pattern is called non-specific interstitial pneumonia. IPF has a very, very, very poor prognosis. In 5 years, 50% die. NSIP has a better prognosis. Also, if you see the treatment, NSIP responds to steroids. IPF has poor response to steroids. Means we give antifibrotic agents like pirfenidone, and there's a drug called nintedanib, tyrosine kinase inhibitor. Can give steroids and immunosuppressants also. So there are some other types also, like systemic sclerosis causes ILD, sarcoidosis causes ILD. I think we can discuss something about sarcoidosis. So sarcoidosis, it's a very enigmatic disease like TB because its correct origin is unknown. Whether it is post-infective, or is it a genetic disease, or is it an autoimmune disease, it's unknown. It mimics TB because there is lymphadenopathy. You see there's a lambda sign. There will be bilateral hilar lymphadenopathy plus tracheal lymphadenopathy. So hilar lymphadenopathy is there. Not only it causes lymphadenopathy, in one stage it can also cause the lung involvement. So it's lymph node plus lung. Because the same combination also occurs in tuberculosis. Right? How will you diagnose? In sarcoidosis, ACE, angiotensin converting enzyme levels are increased. Because ACE is normally produced by the lung. In sarcoidosis, the lung produces excess of angiotensin converting enzyme. And what about the vitamin D? Vitamin D levels increase. Because vitamin D levels increase, calcium also increases. Usually the two most common causes of hypercalcemia are hyperparathyroidism and hypercalcemia of malignancy. Of course, sarcoidosis is also one reason because of hypervitaminosis D. So what will be the pathology? There will be non-caseating granulomas versus tuberculosis, there will be caseating granulomas. Sarcoidosis, there will be non-caseating granulomas. Treatment usually steroids and immunosuppression are tried. Okay. There is a term called as Lofgren syndrome. It's a type of sarcoidosis. So some basics about sarcoidosis. And some discussion may go on the smoking associated ILD. Practically any type of ILD can be associated with smoking, but what is more commonly associated is NSIP can occur. There is something called as DIP, desquamative interstitial pneumonia, there is something called COP, cryptogenic organizing pneumonia. All these are just variants of interstitial lung disease. So at least remember 2 common variants, and you must know how to pick it up in CT image. See, the left side image is IPF. This right side image is non-specific interstitial pneumonia. See here, the predominant honeycombing is there. It is very much peripheral. There's a peripheral honeycombing pattern, reticular pattern. But here there is ground glassing. What is meant by ground glassing? Ground glassing is hyperlucency through which we can see the bronchi. See this black color, we cannot see the underlying tissues. But this white color or this hyperlucency, we are not able to see the underlying tissues. But see this opacity, we can see the bronchus through it. So this is a ground glass opacity. Ground glass opacity typical of NSIP, honeycombing typical of IPF. At least those things can be remembered. I think this is archidosis, bilateral lymphadenopathy. So we finished interstitial diseases and airway diseases. Now coming to pleural effusion. Pleural effusion is a pleural disease. Pleural effusion starts with pleuritis. Okay, pleural effusion starts with pleuritis. Because in the initial pleuritic stage, there will be chest pain. What type of chest pain? Pleuritic type of chest pain. But once the pleural inflammation settles and pleural effusion forms, pain will disappear. This sequence is very important to know because scenarios may be given. Initially there was a chest pain, later on their pain disappeared, but imaging showed pleural effusion. It is typical. So whenever we discuss pleural effusion, we must remember the important criteria. What is that criteria? Light's criteria. Light has written a book called Light's Pleural Diseases. So it's called Light's criteria. In that we have 3 findings. Pleural fluid protein by serum protein should be more than 0.5. Pleural fluid LDH by serum LDH should be more than 0.6. Pleural fluid LDH should be more than 2/3 of upper limit of the normal serum LDH. So the normal serum LDH is, the upper limit is around 300. So what they are given, if the pleural fluid is more than 2/3 of 300, that is, if the pleural fluid LDH is more than 200 units per liter, that is one criteria. Of this, if any one is present, it can be considered as exudate. Of course, there are some other evaluation also, but at least if Light's criteria, one of these 3 is positive, it is exudate. None is present, it is transudate. Why to differentiate this is, we must know the causes of transudatic pleural effusion and exudatic pleural effusion. Same like this in abdomen, we have another factor that is called the SAG. That is serum ascites albumin gradient. That is serum albumin minus ascitic albumin, ascitic fluid albumin. Here, if the cutoff is 1 point, if the difference is more than 1.1, it indicates patient is having ascites due to portal hypertension. It's not pulmonary hypertension, it is portal hypertension. If the SAG is less than 1.1, it is due to other reasons, right? So that is in abdomen. Likewise, here we have Light's criteria. Just for a correlation, I mentioned it here. We'll discuss it in abdomen also. So these are the causes. Transudative pleural effusion is usually due to a systemic disease like congenital heart failure, cirrhosis or liver failure, nephrotic syndrome or renal failure, peritoneal dialysis, myxedema, and SVC obstruction, urinothorax. At least remember the most important causes: heart failure, renal failure, liver failure, and thyrotoxicosis. All the other conditions is exudative, right? Be it infections, be it tuberculosis, be it metastasis, be it malignancy, be it pulmonary embolism, right, be it iatrogenic, all the other causes, and collagen vasculitis, that is connective tissue disorders like SLE. SLE is very important because we have another one finding here. It is bilateral exudative pleural effusion. Usually transudatic pleural effusion is bilateral because it is due to a systemic disease. Exudative pleural effusion is usually unilateral because it is a local disease. But in SLE we have bilateral exudative pleural effusion. That is something to be remembered. Here it has very low glucose pleural effusion. Because if you check glucose in pleural fluid, it will be very low. Okay, so other causes we are not discussing here. Right, so this is pleural effusion. How will you treat? Not all cases of pleural effusion will require ICD because in transudatic causes it's a systemic disease. So there is no need to tap, it's enough to give diuretics. Systemic causes, in exudative causes, you have to treat the cause. Mild pleural effusion can be left as such, or we can do a drain. ICD, there are only few indications for intercostal drain tube placement. One, there is an established empyema, or there is infection. For example, culture is positive, or if glucose is low. If glucose is low, it indicates that there is some organism consuming glucose. So low glucose, high LDH, presence of organism positivity, all these things indicate ICD. We will discuss another pleural disease which is pneumothorax. Pneumothorax is air accumulation in the pleural cavity. So pneumothorax, usually there are few types. For example, we have something called as primary spontaneous pneumothorax. Primary pneumothorax occurs without any systemic disease. Spontaneous, it occurs without any trauma. Likewise, we have primary iatrogenic pneumothorax. Primary means patient is not having any lung disease. Iatrogenic, it occurs due to some, for example, they have a trauma, right? Trauma or a bullet injury or some needle prick. Somehow they get pneumothorax. Or how the needle prick occurs is for central vein insertion. Okay. Then we have secondary spontaneous pneumothorax. There is secondary means there is some lung disease like COPD. A COPD will usually have bullae. Those bullae rupture to cause pneumothorax. Similarly, we have secondary iatrogenic pneumothorax. Explain. One term called as open pneumothorax is used. When pneumothorax communicates with the exterior, it's called open pneumothorax. So it is treated with the three-sided taped bandage. But what is more important is tension pneumothorax, identifying tension pneumothorax. Tension pneumothorax is an emergency. So what is tension pneumothorax? So assume that this is the pleural space and I am drawing the lung inside. There is a rupture here. So air starts leaking and air fills the pleural cavity. Now, some of the air can enter back into the lungs, but assume that there is only one valve-like phenomenon. The air only goes out and it never comes back inside. So what happens? The air starts accumulating around the pleura. It will start compressing the lung. When it starts compressing the lung, what happens? Blood doesn't flow from the lungs to the heart. So BP drops. JVP rises because blood doesn't even enter the lung. So JVP rises, BP drops. And what is the auscultatory finding? Absent lung sounds. I think we would have discussed the same triad. Distant heart sounds, elevated JVP, low BP is also finding in cardiac tamponade. The same findings here occur in tension pneumothorax. So tension, and the same finding also we get pulsus paradoxus. Pulsus paradoxus is paradoxical fall of systolic BP more than 20 mmHg on deep inspiration. Sometimes there will be absent heart sounds also. When the heart is dislocated, there will be absent heart sounds also. This is an emergency. So how will you treat? We don't have time to arrange for the ICD. So what is done immediately is prick the needle thoracostomy. Air is always above. So we have to prick the second intercostal space, right? Because in pleural effusion ICD, we prick at a different side. We usually put it in the fifth intercostal space because fluid is down. Whereas air is up. So in needle thoracostomy, we put the needle in the second intercostal space in pneumothorax. Followed by this, when there is time, we do ICD. Okay. So this finishes pleural diseases. Now coming to the mediastinum. So mediastinum is the component, or it's the place where the heart and the lung rest. So there are actually three compartments: anterior compartment, middle compartment, and posterior compartment. Why we must know the mediastinum is, in doing an X-ray, sometimes we may come across masses or tumors. We are supposed to find out whether it is in the anterior mediastinum, middle mediastinum, or posterior mediastinum. Middle mediastinum has the heart, right? Middle mediastinum is easy to remember because middle mediastinum only divides the anterior and the posterior compartment. So the middle has the heart, the pericardium, the heart and its vessels. So SVC, IVC, arch of aorta, the pulmonary arteries, everything. The heart and its associated is present. In front of that is anterior compartment. Behind that is posterior compartment. So what is present anterior to that? The thymus gland, the mediastinal lymph nodes, internal mammary arteries and veins. So the tumors arising from that will be thymoma, lymphoma, some mesenchymal tumors, etc. Mainly remember thymoma, right? Some divide anterior compartment into superior, middle and inferior. Now what about posterior compartment? What is behind the heart? The aorta is there, esophagus is there, and when thinking of aorta, think of esophagus, the thoracic duct, hemiesophagus veins, sympathetic chain, and the vertebral column is behind, right? So aorta, esophagus, esophagus and hemiesophagus, sympathetic chain. So tumors of all these can occur. So since the sympathetic chain is there, there can be neurogenic tumors, esophageal tumors, right? Esophageal hernias, etc. So this is actually the Felson's criteria. So suppose if an image is given, think that this is the heart, right? This is the lateral view of the X-ray. This is the heart. So in front of the heart is anterior. So this part is the anterior mediastinum. The heart itself is the middle mediastinum, right? So this entire thing is the middle mediastinum. Behind the heart, so the arch of aorta, the sympathetic chain, everything is the posterior mediastinum. So if an image is given, whether it is CT or X-ray, try to find out where the mass is, and maybe you can make a reasonable guess. So another short discussion on obstructive sleep apnea. Obstructive sleep apnea is also an airway disease, practically speaking, because there is an obstruction. So sleep apnea is of two types. We have central sleep apnea and obstructive sleep apnea. Before that, what is apnea? Apnea is cessation of breathing for 10 seconds during sleep. Cessation of breathing for 10 seconds or more is called as apnea. If the cessation is due to absence of respiratory effort from the center part, from the brain, it's called as central apnea. If there is cessation of breathing Despite an respiratory effort, it is called as obstructive sleep apnea. So something is obstructing the airway. So hypopnea is 30% reduction in airflow for 10 seconds. So absent breathing for 10 seconds is apnea. 30% or more reduction in airflow is called as apnea. There will be 3% desaturation. So even if you are not able to document apnea, a 3% drop during sleep is called as hypopnea, right? Based on this apnea and hypopnea, so apnea is cessation of breathing for 10 seconds. Hypopnea is 30% or more reduction in breathing for 10 seconds or more. If you combine the number of events together, the number of apneas and hypopneas in hour is called as apnea-hypopnea index. This is used to classify obstructive sleep apnea because 5 to 14 is mild OSA, 15 to 29 is moderate OSA, 30 events or more is severe OSA, right? So in whom does obstructive sleep apnea occurs? Something has to obstruct the airways. So usually occurs in obese. So when can you suspect? There are some scores such as stop bank score. So usually suspect it in an obese person who has systemic hypertension. Why systemic hypertension? They have interrupted sleep, so there is systemic hypertension. They have pulmonary hypertension because of the chronic hypoxia, because there is nocturnal desaturation. This chronic nocturnal desaturation leads to pulmonary hypertension. They will be sleepy in the morning. So while continuing some activities or during some relevant activities like driving, etc., they feel sleepy because they don't sleep in the night properly because of the hypoxia. So people with these complaints, and there's a history of snoring. So when some of these markers are present, you can consider that they may have OSA. The stop bank score, etc., will help to quantify the risk whether they are having OSA or not. But how will you diagnose it? Sleep study. Whether it is OSA, whether it is central sleep apnea, or any sleep-related disturbance, we can do sleep study. Sleep study calculates what? Apnea-hypopnea index. How will you classify? Mild, moderate, or severe. 5 to 14 AHI is mild, 15 to 29 is moderate, 30 or more is severe. So how will you treat? By giving positive airway, the CPAP which we had discussed, okay, CPAP. Of course, surgery may be an option. Suppose if the obstruction is due to a tonsillitis, or if the obstruction is due to a tissue, or if obstruction is due to a soft tissue mass inside, we can do a surgery. There are some mandibular advancement devices also, but if one better treatment is OSA, CPAP. Nowadays, another important treatment is coming up, tirzepatide. So we know tirzepatide is a twincretin agonist. That is, it's a GIP-1 and GLP-1 analog. Like semaglutide, tirzepatide is a GLP-1 and GIP-1 analog. So this has been FDA approved for obesity. As we know, obesity is the main risk factor for OSA. So if obesity is reduced, obviously sleep apnea will reduce. So tirzepatide is an FDA approved. If someone asks what is the medical treatment, tirzepatide is the answer. Otherwise, overall, what is the treatment? It is CPAP. Okay. So we are quickly going through some short topics. What is about lung transplant? So lung transplant is done frequently for people nowadays. So what is the most common indication? COPD. Of course, other causes like congenital lung diseases like alpha-1 antitrypsin, that also leads to COPD. Bronchiectasis, some tumors. For these conditions, we can do lung transplant. So what are the criteria for an ideal donor? Donor should be less than 55 years. ABO should be compatible. His chest X-ray should be clear. PF ratio, that is PaO to FaO to ratio, with a PEEP of 5. PEEP of 5 is the normal PEEP. Something on physiology, we are not discussing that. It should be more than 300. If you remember, this PF ratio is something which is used to quantify ARDS also. So PF ratio should be more than 300 is normal. So his tobacco history should be less than 20 pack years. Pack years is number of packs per day into the number of years smoked. So he should have less than 20 pack years. He should not have a chest trauma. He should not have aspiration, because aspiration can lead to bronchiectasis. We had discussed. He should not have prior thoracic surgery. His sputum should be negative, and bronchoscopy should not show any purulent secretions. As if it shows, he will have recurrence of the condition. So these are the criteria for lung donor and the common indications. Now ARDS, another very important. ARDS is acute respiratory distress syndrome. It is one condition which causes type 1 respiratory failure. So we will see what is the diagnostic criteria. This is the 2012 Berlin criteria. So what is this acute respiratory distress syndrome? So we just discussed an entity called as PaO2 FaO2 ratio. PaO2 is the partial pressure of oxygen in the blood. FaO2 is the inspired fraction of oxygen. That is, normal air has 21% oxygen. So FaO2 of inspired air is 0.21. If you give 100% oxygen to mask, the FaO2 is 1. Suppose if you give 60% of oxygen through any oxygen delivery device like Venturi mask, they will have 0.6 as the FaO2. So you can calculate PF ratio by the values given. Normal PF ratio has to be more than or equal to 300. So if PF ratio is less than 300, it is one criteria for ARDS. So we can quantify also. If the PF ratio is 200 to 300, it is mild. If it is 100 to 200, it is moderate. Less than 100 is severe ARDS. So this is one criteria, PF ratio. And when should this PF ratio should fall? The onset should be within 1 week of a clinical insult or new or worsening respiratory symptoms. For example, patient had developed pneumonia on 1st of August. On 5th of August, he develops increasing breathlessness despite treatment. That is ARDS. Patient is given blood transfusion today morning. Today evening, he develops another breathing difficulty, unrelated, the reasons unknown. It is transfusion reaction associated lung injury. Patient is getting treatment for sepsis. You have done everything on today. Tomorrow when you see the x-ray, some findings are there. He develops increasing breathing difficulty, PF ratio becomes low. That is ARDS. So whatever be the clinical insult, I will show you the causes also. Whatever is the cause, systemic cause or a lung related cause, within 1 week of that particular disease, patient should develop a new or a worsening respiratory symptom. Then only it is called as ARDS. This is the second criteria. Then we have an X-ray finding. So a clinical finding, X-ray finding and a ABG finding. So X-ray should show bilateral opacities consistent with pulmonary edema, not fully explained by effusions, lobar or lung collapse or nodules. That's bilateral opacities which does not have any other explanation. There shouldn't be effusion, there shouldn't be collapse or nodule. And without any reason, he should have lung nodules. Plus, there should be absence of left atrial hypertension, because left atrial hypertension is actually cardiogenic pulmonary edema. Right? When left atrium becomes hypertensive, the pressure will be transmitted to the pulmonary veins, to the pulmonary capillaries. Pulmonary capillaries will lead to cardiogenic pulmonary edema. This finding should be absent because this is a non-cardiogenic pulmonary edema. ARDS is called as non-cardiogenic pulmonary edema. So if a patient is having a cardiac disease, there is left atrial hypertension, there is another measure like pulmonary capillary wedge pressure is one invasive method to find out whether it is cardiogenic pulmonary edema or not. The pulmonary capillary wedge pressure is more than 18, which means there is intra-atrial hypertension. So it is cardiogenic pulmonary edema. This finding should not be there. Only when cardiogenic pulmonary edema is ruled out, There is bilateral lung opacity. Onset of illness is within 1 week of a particular insult and PF ratio is low. It is called as ARDS. So these are the causes. So it could be direct causes and indirect causes. Direct causes are lung related conditions. For example, pneumonia. So it could be pneumonia, aspiration, pulmonary contusion, nothing but lung injury, near drowning, toxic inhalational injury. So if it is localized with pneumonia alone, it is not a problem. But when it extends to the other lung, it causes ARDS. Now systemic conditions, sepsis, the example which I told. Severe trauma. So in surgical ward, following injury with the patient develops breathing difficulty, one of the DD is ARDS. Not only in trauma ward, in burns ward, in neurosurgery ward, right? Multiple transfusion, that's called as TRALI, transfusion reaction associated lung injury. It is ARDS which occurs within 6 hours of transfusion. Why does it occur? The donor blood has some antibodies which attack the recipient cells. Could be some drug induced pancreatitis, again in surgical ward, and post cardiopulmonary bypass. So these are the systemic conditions which cause ARDS. So these are the phases of ARDS. So there is initially an exudative phase where there is edema and hyaline membrane formation. So we know in pediatrics that's something called as neonatal respiratory distress syndrome. Hyaline membrane formation is a feature of NRDS also. So this is like a mimic of NRDS in adults. So there is exudative phase, proliferative phase where there is inflammation, and fibrotic phase beyond 21 days. See, this is how you suspect ARDS. Bilateral lung opacities which is not explained by any other finding. Plus they should have this finding or breathing difficulty within 1 week of developing a clinical insult, and they should have PF ratio less than 300. Provided we should distinguish it from LV failure. Again it tells the phases: exudative phase, proliferative phase and fibrotic phase. Now how will you treat? Obviously first thing is treat the cause. Now which are the evidence proven methods to treat? Don't see the other things, see only the A and B recommendations. It is low tidal volume and high PEEP. So first thing is ventilation. Definitely we have to put them on ventilator, either non-invasive ventilation or invasive ventilation. What strategy we use is low tidal volume. Normal tidal volume, we know it is 500. So it is low tidal volume, high PEEP or optimal PEEP. Why low tidal volume? Because if you give large tidal volume, the lung will get distended and lungs may rupture. So this is called as lung protective ventilation. So the low tidal volume is called as lung protective ventilation. Why high PEEP? We discussed the pathologies. There is exudation. There is edema and exudation. Those edema and exudation will close the alveoli. When we give high PEEP, normal PEEP is 5. When you keep PEEP more than 5 centimeters of water, lungs will expand. PEEP is positive end expiratory pressure. So if you give a pressure more than 5 during end of expiration, lungs will be kept open during inspiration, right? Because normally in ARDS what happens, because of exudation during inspiration, alveoli is already collapsed. So if you give a PEEP during inspiration, it will open. So high PEEP and low tidal volume. Next is minimized left atrial filling pressure. So how can you do it? By diuretics to prevent further fluid overload. So already we are having a non-cardiogenic pulmonary edema. If you give diuretics, we can reduce the chance of cardiogenic pulmonary edema also. Next is prone position. Prone position opens the base of the lung. So low tidal volume, high PEEP, prone position and minimalized left atrial filling pressure are diuretics. These are the evidence proven. There are some other methods. ECMO can be used in severe cases. So now pulmonary hypertension. Usually there is a saying telling that onset of pulmonary hypertension is the beginning of the end of the patient. Because assume any severe lung disease like ILD, COPD, OSA or bronchiectasis. When they become severe, it leads to pulmonary hypertension, cor pulmonale. Once they develop pulmonary hypertension and cor pulmonale, prognosis is poor. Assume heart diseases like any valvular heart disease. When they develop pulmonary hypertension, valvular heart disease also lead to pulmonary hypertension, poor prognosis. And pulmonary hypertension itself is a poor prognosis. That's why it's the beginning of the end of the patient. So how will you define pulmonary hypertension? Is mean pulmonary artery pressure more than 20 millimeters of mercury and pulmonary vascular resistance more than or equal to 3 Wood units, something which has to be memorized. So there are 5 types of pulmonary hypertension. One is primary pulmonary hypertension, that is there is no other cause of pulmonary hypertension, it's an idiopathic condition. Pulmonary arterial hypertension, group 1. Group 2 is pulmonary hypertension due to left heart disease. So for example, mitral stenosis, mitral regurgitation, etc. Third category is pulmonary hypertension due to lung disease. This is what we discussed, the ILD, COPD, bronchiectasis, etc. Fourth category is chronic thromboembolic pulmonary hypertension due to chronic pulmonary embolism. Prior, like suppose they had a prior pulmonary embolism, it can have a chance of recurring. That pulmonary hypertension, pulmonary embolism in future leads to pulmonary hypertension. Next is 5 is rare or mixed varieties. Remember, the primary pulmonary hypertension also includes congenital heart disease. It also includes connective tissue diseases like SLE, systemic sclerosis. So remember the cutoff: pulmonary artery pressure more than 20, pulmonary vascular resistance more than 3. So we are discussing just previously, in cardiogenic pulmonary edema, pulmonary capillary wedge pressure will be high, right? So why this pulmonary capillary wedge pressure is high? It is due to a post-capillary phenomenon, right? Pulmonary arteries form the pulmonary capillaries form the vein. So pulmonary veins are post-capillaries. In heart failure, the pulmonary edema occurs due to a distension of the pulmonary vein. So it is a post-capillary phenomenon. Now the chronic hypoxia due to the pulmonary edema leads to pulmonary hypertension. So the group 2 pulmonary hypertension is actually post-capillary. So why this post-capillary or pre-capillary word is important is while doing invasive hemodynamic testing, they test all these things, right? So that just for a theoretical sake. See, on doing right heart catheterization, if the mean pulmonary artery pressure is more than 20, only then it is pulmonary hypertension. Now our question is the pulmonary capillary wedge pressure more than 15? If it is so, it is group 2, right? Don't remember this, it's group 2. Suppose if the mean pulmonary artery pressure is less than 15, it has to be precapillary. In that case, you have to see the pulmonary vascular resistance. If it is high, it is precapillary pulmonary hypertension, right? So mean pulmonary artery pressure more than 20, pulmonary vascular resistance more than 3. At least remember this one. Okay. How will you treat? We have to reduce pressure. So some groups of drugs are there. One group is prostaglandins. Prostaglandin E, prostaglandin I, all those cause vasodilation. So that is the mechanism of action. Next we have selexipag. Bosentan, ambrisentan and macitentan. They are endothelin receptor antagonist. Endothelin causes vasoconstriction, antagonization causes vasodilation. Sildenafil, tadalafil. They are phosphodiesterase 5 inhibitors. When phosphodiesterase 5 is inhibited, cyclic AMP increases to cause vasodilation. Riociguat is a cyclic GMP activator or guanylyl cyclase stimulator, right? So you have 4 groups: prostacyclins, endothelin receptor antagonists, phosphodiesterase inhibitors and phosphodiesterase 5 inhibitors and cyclic GMP. Coming to cancers of the lung. Cancers of lung are also very good discussion topics. We have 4 types of cancers in the lung: squamous cell, large cell, small cell, and adenocarcinoma. But we tell them as small cell cancer versus non-small cell cancer. Non-small cell cancer is squamous cell, adenocarcinoma, and large cell carcinoma. All cancers except adenocarcinoma of the lung are smoking associated, which means small cell cancer, squamous cell cancer, large cell cancer are smoking associated. So if a lung cancer occurs in a female and non-smoker, we have to think of adenocarcinoma. So whenever there's a cancer, there has to be TNM staging, there has to be some gene which is activated. At least remember few of the genes. This HER2, KRAS, BRAF, such things are associated with adenocarcinoma. FGFR1 amplification is associated with squamous cell carcinoma. P10 is squamous cell carcinoma. Why we should know these things? Because there are some antagonists specifically. FGFR1 antagonist or tyrosine kinase antagonist can be used in squamous cell carcinoma, like that. Right. So this will be discussed in pathology. Just I'm giving a gist. Now this we can discuss. So what are the symptoms? Weight loss. Obviously any cancer can cause weight loss. Musculoskeletal pain. Headache, syncope, seizures, recent change in mental status because metastasis, brain mets. We have to think. We'll discuss the other things. Any lymphadenopathy, we have to think of lymph node metastasis in cancer. Self-explanatory. Now what about superior vena cava syndrome? Since lung is close proximity to the SVC, small cell cancer, it can occlude the SVC to cause SVC distension. That's called as SVC syndrome. Small cell cancer causes SVC syndrome. So there will be a puffy face, congested face. Okay. Now bone tenderness. Bone tenderness can occur either due to bone mets or because of hypercalcemia of malignancy. So what is the basis is the small squamous cell lung carcinoma. Please remember the squamous cell lung cancer produces a protein called parathyroid hormone related peptide. This is like parathyroid hormone. One of the function of parathyroid hormone is to bring out calcium from the bone, causing hypercalcemia. So there is bone tenderness in squamous cell carcinoma. There can be hepatomegaly, liver mets, focal neurological signs, and papilledema. Focal neurological signs is again spread of the lung cancer to the brachial plexus. This also is common with small cell lung cancer. Another peculiar disease also occurs in small cell lung cancer, that is Lambert-Eaton myasthenic syndrome. It is a disease closely related to myasthenia gravis, where the disease is due to VGCC antibody, voltage gated calcium channel antibodies. This voltage gated calcium channel is present in the presynaptic membrane of the neuromuscular junction. When it is damaged, acetylcholine release will not occur from the neuromuscular junction, leading to muscle weakness. Here in repetitive nerve stimulation, we get a finding called as incremental response. In myasthenia gravis, we have decremental response. So treated with plasmapheresis. It is a paraneoplastic manifestation due to small cell lung cancer. So if the patient has ptosis, etc., we can think of small cell cancer, or there can be a soft tissue mass. So see lab test, we get to see elevated calcium levels. We have to see LFT. Why LFT? Liver mets. Why you have to see hematocrit? Again hematocrit, erythropoietin may be secreted by small cell cancer. So what we understand here is small cell cancer is very important to remember because it produces so many clinical symptoms. Like it can produce SVC syndrome, it can produce Lambert-Eaton myasthenic syndrome, it can cause polycythemia. Polycythemia can also occur due to chronic hypoxia. Squamous cell carcinoma is the only exception because it causes hypercalcemia of malignancy. So treatment of tumors will be based on TNM staging, either surgery or chemotherapy. Now pneumonia. Pneumonia is nothing but consolidation of the lung or infection of the lung. So we must know the organisms, whether it is in outpatient setting or it is in the non-ICU admission or ICU admission. Streptococcus pneumoniae is the most common organism. Something to be remembered. Streptococcus pneumoniae is the most common organism. We have a scoring to tell the severity of pneumonia. That's called as Cup-65 score. So one is consciousness, next is urea level, next is respiratory rate, next is BP, that is systolic BP, and 65 is age more than 65. So if the patient is unconscious, 1 point. If the urea is more than 40 milligrams per deciliter, the units may be given differently in textbooks, but if the urea is more than 40, it is 1 point. Or if the respiratory rate is more than 20, again 1 point. BP, if the SBP is less than 90 and DBP is less than 60, it carries 1 point. Age more than 65 is 1 point. Isn't curve 65, 0 or 1 is treated as OP. 2 is treated as IP. 3 or more needs ICU admission. The scoring is also important because this decides the treatment. So Harrison gives it differently, but here I am using the Indian guidelines to say. Because if the patient is asked to be treated as OP, see if the patient has comorbids. If the patient has no comorbids, 1 antibiotic is enough. 1 antibiotic either can be a macrolide alone or doxycycline alone or penicillin alone. Suppose if the patient has comorbids, we must give 2 antibiotics. 1 macrolide or doxycycline for atypical cover plus a penicillin group for typical cover. So we must know what is the typical organisms and atypical organisms. I told you the most common organism causing pneumonia is Streptococcus pneumoniae. Then we have Haemophilus influenzae. Streptococcus pyogenes. So these are the typical organisms. What are the atypical organism causing pneumonia? Mycoplasma, chlamydia, Legionella. Moraxella. So these are the typical and atypical organisms. So suppose IP case, what will you treat? Definitely we need 2 antibiotics. In that one group should be an IV antibiotic. If 3 or more ICU treatment, in ICU treatment we have to give a drug with MRSA cover like vancomycin or linezolid. Plus we should give 2 antibiotics. Those 2 antibiotics must cover Pseudomonas. Because ICU admission, Pseudomonas is common. So what are the anti-pseudomonal antibiotics? Piperacillin tazobactam, cefoperazone, aminoglycosides, fluoroquinolones. The fluoroquinolones used here are moxifloxacin and levofloxacin. Okay. So that was about short discussion. Based on some clinical clues, we can find out. I am telling you about Legionella. Legionella occurs when people stay in the hotel or cruise. So because AC is the triggering factor for Legionella. Now when do you suspect Burkholderia? Patient is having bronchiectasis, right? This also discussed. So whenever Pseudomonas is there, think of some structural lung disease. When do you suspect chlamydia? Exposure to birds is there, right? When local influenza activity is there, think of influenza virus. When there is exposure to sheep, think of Coxiella burnetii. Exposure to rabbits, Francisella. Right? So based on the clinical clue, Legionella becomes more important here, which you must remember. Stay in hotel or cruise, think of Legionella pneumonia. Right. So that was about community acquired pneumonia. Now about ventilator associated pneumonia, think of the common organism. Streptococcus pneumonia and Pseudomonas. When you think of multi-drug resistant, it is Pseudomonas. So this completes our detailed discussion on